This case is titled A Case of Mistaken Identity because it was a boy lesion that was misdiagnosed as degenerative uterine fibroid in a 56-year-old who was 6 years postmenopausal. She first presented to the SOPD with bowel symptoms and had 2 ultrasound scans by 2 different specialists. Both made diagnosis of uterine fibroids with calcific degeneration. The gynecologist was not comfortable with this diagnosis, and so a CT scan was requested. But in addition to a diagnosis of uterine fibroid with calcification, we now have an additional diagnosis of endometrial cancer. As gynecologists, we know that the friendliest of all gynecological malignancies is endometrial cancer because it presents early with postmenopausal bleeding in 95% of the cases. So now we look at the images and see where the misdiagnosis was made and how to prevent future diagnostic mishaps. These are still images. Here you have this pair mode. The bladder was not full. So here, not this echogenic area. This echogenic area in the pelvis should raise a red flag that this is unlikely to be of uterine origin. Agreed. In a few cases, one may encounter lipomyoma. Again, the echogenicity of this lesion is not typical of a uterine lesion. Here, look at the differential echogenicity between this area and this area, and not the irregular boundary of this more echogenic area. So this has mixed echogenicity. Less echogenic area here and a more echogenic area here. Again, not this clump of calcification, which is casting acoustic shadows. This was probably why a diagnosis of calcified uterine fibroid was made. But on careful assessments of this lesion, one will see what looks like a haustra here, another haustra here, and you can see one here, giving a possibility that this could be a bowel lesion. Again, when one looks at this area, you can see that this is the cervix and this is the fundus of the uterus here. And look at the endometrial canal here. Look at the endometrial stripe, thin linear endometrial stripe. So this lesion is sitting in the uterovesical pouch and has pushed the uterus downwards, as can be seen clearly in these images. This is the upper aspects of the same lesion. Here, not this, and this. This could represent bowel prostration, not the clump of echogenic lesion here, casting acoustic shadow. Here, what looks like the ball histration has taken up color. This also has taken up color. And you can see central color flow here. Generally, the color flow to fibroid is usually peripheral, although central blood flow may be seen in cases of degenerated uterine fibroid. Again, here around the region where this calcific clump was seen, not this color uptake. Not only that, this color uptake is not normal, because here you can see what looks like slight aneurysm, then stenosis, aneurysm, stenosis. So this bidet appearance of this color is suspicious. Again, not what looks like bowel signature here, the host traces.
Wanda ka gan shi duk wajen nan babba ne da yaro ba dan akwai tica ba shi ma ba zai iya ba.
On 3D, note the heterogeneous nature of the mass in the lower aspect. This is the bladder. And look at the chaotic vascular pattern. Here you can see looping here, and a looping again, and a looping, dilatation. You can see some stenotic area here, some branching here. So these are features that are suggestive of malignancy. Again, this is a 3D color using glass body. So in the course of acquiring the rendered image, there was peristalsis, and that was why we have this motion, artifact blurring the view of the vessels. But nonetheless, these features can clearly be demonstrated here. First, this area shows looping. Here you can see the stenosis, the dilated segments, and the branching here. So all these are features suggestive of malignancy. Look at the uterus here. Look at the differential echogenicity between the lesion and the uterus and the bladder. The rendered image here shows the lesion. Here is the bladder, and you can see the bladder wall is well preserved. So we decided to do saline infusion sonography, and as expected, the postmenopausal uterus is in many cases axial, as you can see here, and that is why it's difficult to assess the endometrial thickness. Here you can see the catheter balloon and the measurement of the uterus here, and not the clear demarcation between this lesion and the uterus. Look at the clear demarcation between the lesion and the uterus. After withdrawal of the catheter, you can see the endometrial cavity. In fact, the endometrium was immeasurable. These are air bubbles as a result of the saline infusion, and you can see here the endometrial cavity. So here is the upper aspect, again, not these hostrations here, and not the fan shape appearance of the upper aspects of the lesion. Note that the clamp of calcifications and the acoustic shadowing. Now let's look at the video here. So look at the peristalsis. Look at the acoustic shadows here, also moving with the peristalsis. So this confirms this lesion as arising from the bowel and not from the uterus. So the take-home message is that a detailed and focal history will make many diagnostic tests unnecessary. And let's always remember that not all masses in the pelvis are of gynecological origin. Thank you.